Muy bien, creo que es momento de empezar para no retrasarnos y solo quiero un poco repetir en este momento, mi nombre es Carlos Cáceres, director del Centro de Investigación Interdisciplinaria en Sexualidad, Sida y Sociedad de la Universidad Cayetano Heredia, y tengo el gusto de tener aquí a mi lado al doctor Ken Mayer, que es profesor de la Universidad de Harvard y una persona que ha sido clave en el desarrollo de la temática en salud LGBT en Estados Unidos, uno de los promotores del Instituto Fenway. Él además sigue trabajando y haciendo mucha investigación en VIH y en otros temas en el Instituto Fenway y en varias de las redes que tienen que ver con VIH y con otros temas de salud LGBT en Estados Unidos, ¿no? Entonces, lo que voy a decir brevemente es que, ¿por qué estamos acá? En los últimos años se ha observado importantes mejoras en la actitud del público hacia las comunidades lésbico, gay, bisexuales y transgénero en el país, pero no solo en el país, sino también en la región, en el mundo. Y estos se han traducido en cambios legales favorables, han significado en la práctica el reconocimiento de comunidades como estas que, debido al estigma preexistente, permanecían ocultas, con ejercicio limitado de sus derechos. No existían, ¿no? Dicho reconocimiento, ¿no?, actual implica, entre otras cosas, la necesidad de responder a las necesidades específicas de tales comunidades en salud, educación, justicia, trabajo, otras esferas de la vida pública. En la práctica esto equivale a descubrir nuevas comunidades como sujetos de derecho y decidir actuar, ¿no? Para que ello ocurra en el campo de la salud se requieren cambios en la normatividad sectorial, como en la organización de entidades prestadoras de servicios, de salud, en la formación de profesionales de salud, ¿no? Y otros, ¿no? Pero de la formación de profesionales es un tema relevante para las universidades. Bueno, entonces, hace un tiempo estamos acá en Cayetano Heredia con la Facultad de Medicina, con, digamos, la participación de la OPS, una discusión sobre cómo estos temas podrían tener una presencia mayor en el currículum, porque nos sucedía que venían estudiantes o personas que habían terminado la carrera y que no sabían cómo, a veces, trabajar con pacientes, con personas LGBT, ¿no? Sabían que había cosas que no habían aprendido, ¿no? Entonces, fue un momento de descubrimiento, de que se concretara esta noción de que hace falta actuar. O sea, los cambios no ocurrieron automáticamente, ¿no? Hay que pensarlo, hay que ver cómo esto se articula. Entonces, de hecho, en este marco hemos tenido la suerte de que el doctor Ken Mayer, y de hecho menciono que él está acá esta semana para una investigación que tienen junto con Impacta, entonces agradecemos a Impacta que haya, digamos, ayudado que se articule el horario que él ha tenido con la visita que pueda hacer acá. De hecho, nosotros en la universidad también tenemos otro proyecto en colaboración con Fenway, ¿no?, que tiene que ver con salud trans, y es muy interesante poder, en ese sentido, invitar al doctor Mayer, que es no solo un investigador muy productivo, sino una persona de primera calidad, excelente, para que venga, ¿no?, y a pesar del cansancio, porque he estado trabajando todo el día, darnos una presentación, ¿no? Ahora sí, dejo al doctor Mayer, ¿no?, con esta presentación. Atención integral, preventiva, de salud de pacientes de minorías sexuales y de género. So I leave Dr. Mayer for this presentation, Comprehensive Preventive Health Care for Sexual and Gender Minority Patients.
Thank you. Muchas gracias, Professor Cáceres. It's a great honor to be here back at Cayetano Heredia University. Professor Cáceres is somebody I've known for many years and have very high regard, and he's been a great scholar in this field of HIV and has a very comprehensive understanding of social and biomedical factors. So it's great to be here, and I hope this is the beginning of a new collaboration together. So just to tell you a little bit about the Fenway Institute. So this is our building in Boston. Fenway Health is a community health center. So the numbers there, 501c3, mean a tax-exempt organization in the United States. So the health center was founded in 1971. The institute is the part of the health center that's not doing primary care for patients. Fenway provides primary care for 30,000 patients. About half are LGBT, half are people who live in the local community. The institute does research, education, and policy dissemination, and that's what I'm the co-chair of the institute. So why are we talking about LGBT people? The fact is that in any society, when you measure, depending on how you ask the question, 3 to 7 to 9% of any population are sexual gender minority people across the world. So Healthy People 2020, every 10 years the U.S. government has a document that focuses on the health of the American people. It's a blueprint. It's made about 10 years before to say what are our goals. And for the first time in Healthy People 2020, LGBT people are part of the document. Another very important thing that happened in the last few years is the Institute of Medicine is part of our National Academy of Sciences, and they realize that there's not a lot as much that should be known about LGBT health. So they actually commissioned a panel to investigate what do we know and what are the gaps in sexual gender minority health. So this is something that's becoming increasingly focused in the United States. So what is unique about sexual gender minority health? And we have to understand that LGBT people have health disparities. And in the United States, we talk about health disparities for people from racial and ethnic minority communities, other populations, but it's also clear that LGBT people have health disparities. And very often it's been very much a focus on HIV, but there are many other issues we have to think about. So if we think about stigma and health, there's been a very careful study. One of the scholars, who's somebody who worked with us in Boston, who's now at Columbia University, Mark Hatzenbuehler, showed that people who have internalized homophobia, who don't accept themselves, or who've experienced discrimination and expect rejection, this is associated with increased HIV risk. It's also associated for transgender people, this transphobia, this internalization of the rejection of society, is associated with delays in receiving needed care. So the stigma has effects on health outcomes. In Healthy People 2020, they reviewed the data in the United States, and I'll go back in more detail in a few minutes, but LGBT youth in the U.S. are 2 to 3 times more likely to attempt suicide. They're more likely to be homeless, and that's not because they chose to be homeless. Very often, as they come out, they're rejected by their families, as well as increased risk of STDs and HIV. We also know that LGBT populations have the highest rates of tobacco use, alcohol, and other substance use, and we know that lesbians are less likely to access appropriate cancer screening, mammography, and pap smears, for example. We know that transgender individuals have high prevalence of STDs, victimization, behavioral health issues, and suicide, but there are also structural issues. They're less likely to have health insurance than heterosexuals or even other sexual gender minority patients. And elderly LGBT people, a population that's been pretty invisible until now, have additional barriers because of isolation, fewer family supports, and a lack of social and support services. So because this is a medical school, and many of you are medical students, I just think it's important to step back and say a few things that may be obvious to some people, but many people don't think these through carefully. Sexual orientation and gender identity are not identical. They are really 2 different constructs. So sexual orientation itself is not a simple construct. There's the desire, if somebody wants to have sex with somebody of the same sex, that's not the same as behavior. So there are many people who may have desires for same-sex behavior, but they don't act on it, and that may not equal identity. So there are many men in many cultures, certainly here in Peru, there are men who may say that they're heterosexual, but may be having sex with men. So if we really want to understand sexual orientation, we have to ask questions about identity. If we're interested in epidemiology, about HIV transmission, then we ask questions about behavior. Identity is important for education. Behavior is important to understand who transmitted what to whom. And attraction and desire is also a very important part of this as well. So MSM is an epidemiologic term. So this cartoon, the two men standing here, they say to the older woman, "No, we're not twins." So in other words, they correspond to a stereotype of what gay men may have looked like at one point in time. But if you compare that to, we work with a group in India, the Humsafar Trust, and they talked about the MSM cosmology. So this graph here, all the different circles are different identities in India. So the big yellow is these are people who are men who are having sex with men. Some of those individuals are traditional transgender people, hijras. So there's a construct there. So they're male at birth. They don't identify as male, but they're having sex with other men. So are they MSM? There are other individuals who are male sex workers who identify as heterosexual, but for them, engaging in sex is a means of an income. So we have to be careful when we use these terms. So many people who do HIV work are used to using the term MSM, but MSM is a convenient term. It's not necessarily something that's going to help us ask people in a clinical encounter, who do you think you are? What do you think you're, what is your attraction? What is your behavior? If we're going to do counseling and education, we have to think about those questions. The MSM term is convenient if you're thinking about budgets for global funders, but it really has to be broken into the constituent components. When we talk about gender, we also have to separate gender identity. What does a person think they are? In other words, I may be male at birth, but I may think that I'm a woman. We also have to think about gender expression. So particularly people who are transgender may go through a transition process, and the transition may be a transition in their internalization of who they are and in their expression of who they are. And the gender identity is not necessarily congruent with sex at birth. So we really have to be careful about the different terminology. And the terminology is something that continues to evolve. And the reason I'm commenting on this now is because when we talk about clinical work, if we want to make patients feel comfortable, we have to use terms that they use and they identify with, and not terms that are convenient for us. So again, sexual orientation, whom are you physically, emotionally attracted to, who do you have sex with, how do you identify your identity? Gender identity, what's your internal sense of which gender you are? Sex itself is expression of anatomy, and then gender expression, again, maybe not totally in alignment, and that, again, is another construct. And then you add to this another concept that I'm sure Professor Casares has talked to you about, intersectionality. It may be convenient for us to talk about gay men or MSM or lesbians, but that individual has many other identities and facets of their personality. So in the US, for example, race, ethnicity becomes a very important factor because of social discrimination, historically, culturally, very different. And so an individual, there may be two men who have sex with men, but they may be very different because one is in the dominant culture, is Caucasian, the other may be a black MSM. And epidemiologically, for example, our HIV epidemic is disproportionately among men who have sex with men from communities of color. And some of that is because of assorted mixing, people being more likely to have partners from within their own community. And some of that may be because of lack of access to supportive services. So intersectionality has to be also thought of when we're talking about sexual orientation, gender identity. So when we bring this all together in the clinical space, what do we have to think about? Well, some of the questions are, when we talk to patients, has a clinician ever talked to somebody, we interview people in some of our studies at Fenway, and people who are 60, 70 years of age, their provider never asked them about what their sexual identity was, what their gender identity was, and we've talked to clinicians, and they also oftentimes don't think of this as important. In fact, there was one one study of HIV-infected patients several years ago, published in the American Journal of Public Health, and they talked to patients living with HIV, and although almost all, 84%, said that their doctor talked to them about the importance of adherence to medication, only 14% said that their doctor talked to them about HIV transmission risk. Now, some doctors feel it's stigmatizing to talk to an HIV-infected person that they might be likely to transmit HIV, but it's almost like neutering the person, saying, well, once you have HIV, you don't have a sex life anymore, to not talk to your primary care patient about their sexual behavior. So this has been a problem for a long time. So I mentioned the Institute of Medicine. They had a report about STDs now 20 years ago almost. And basically, their take-home message was, ironically, it may require greater intimacy to discuss sex than to engage in it. So it's sort of the invisible factor in clinical encounters. It's not that difficult. So one of the things we do at Fenway is we try to make this simple for providers, and we have some grants from the U.S. government to train providers to be more comfortable taking routine sexual histories. All of our documents are available on a website, lgbthealtheducation.org. So if you go to that, there's a lot of links, there's a lot of materials you can download, lgbthealtheducation.org. So basically, when you're taking a history of sexual health, it's the same as, LGBT people are people first and foremost, but they may have some unique health risks. So it's really important to use inclusive and neutral language. And in terms of sexual history, we try to make it routine and make no assumptions. Now, we actually interviewed some providers, some physicians several years ago, and they said the reason they don't do sexual histories is, and they don't ask particularly about sexual orientation, gender identity, they thought that their patients would be uncomfortable. We then did a study in 4 community health centers in the United States. Fenway, which has a large LGBT population, one in Chicago, Howard Brown, also large LGBT, and then 2 community health centers that did not have LGBT specialization. And basically we found that close to 90% of the patients said, I would, including the heterosexual patients, I think it would be fine if my doctor asked me about my sex life. In fact, I'd like it, So patients actually think it would be a good thing. They understand that it's an important part of health, but the providers assume that it's not a good thing. So this Institute of Medicine report basically said that data on sexual orientation and gender identity should be collected in electronic health records. And there's been a big movement in the United States with our Affordable Care Act under President Obama that clinics should be using electronic health records because it's a more systematic way to have better data exchange. So the Institute of Medicine, our highest academic body, said this should be routine. So the federal government has issued a guidance about collecting this information, and they said this data should be collected. So it's definitely part of the move in the U.S. Not that it's happening everywhere, but things have definitely changed over the last few years. So one of the first questions as a clinician is, where do I collect the data? And this is just a flow diagram that shows that it's not, it seems like an easy question, but there's a lot of places you could do it. If you have a clinic, a busy clinic, do you want the front desk persons asking the person publicly, are you gay or lesbian? Are you transgender? Maybe not. So do you have the person fill it out before they go in? That's a question. Do you have the provider do it? If you have the provider do it, that means you're relying on it making it to the chart. There's also something called patient portals now. So in some of the clinics, there are websites, and in order to streamline the visits, patients can actually input information before their visits. So they may get an email saying, you have an appointment with Dr. So-and-so on this day. Can you give us the following information? And so there's studies underway. This is not a settled issue. This is really an area for research, maybe something to look at in Peru. Would people rather put something, do it on the internet, or are they worried that the internet will get hacked? What would happen if they're asked the questions in the clinic? Would they rather wait to have the doctor ask the questions? So this is, it's important to have the data collected, but how you collect the data, there's not a consensus. So the different places where it can be done here. Registration is certainly one place. So here's an example. Also, which questions you ask, because again, in busy clinical practice, you want to have standard questions. You don't want too many questions because clinicians are busy, the clinics are busy. So this question has been one that is one of the more common ones used in the U.S. It's been piloted in several studies about people being comfortable. Do you think yourself as lesbian, gay, or homosexual, straight or heterosexual, bisexual, and then something else. So that's sexual orientation. But there are many ways you can ask the question. Then gender identity is more complex. So one of the thoughts is this three-question sequence. What's your current gender identity? It includes terms like gender queer, which is popular among some young people in the U.S., may not be a term used here in Peru. What was your sex assigned at birth? And then what is your preferred pronoun? And preferred pronoun is very important because it gives the patient the autonomy. So we train people to avoid assumptions. How somebody looks doesn't necessarily tell you what their gender identity is or sexual orientation. So you have to hear how people describe things in their own terms. So we try to train people in the front desk staff, for example, instead of assuming gender if it's a new patient, instead of saying, how may I help you, sir, what about how may I help you? And so you have an open-ended question. Several places like Fenway have tried to sort of pilot making it more normative that the patient has control, so that we have buttons that some people wear on the front desk and say, my pronouns are, and that way other people can say, this is how I want to be called. And some people, there are different styles, different trends. Some individuals have talked about using Z or they because they don't identify as he or she. They prefer something more fluid. So we have to listen and see where people are as this evolves. Terminology, queer was used to be an insult when I was growing up. Some people wear it with pride. Gender queer, again, another term. And some people say, I reject the labels. And we have to respect that and understand it, but we also need to have questions about behavior to understand what are the appropriate screenings to do. Certainly we avoid in clinical care in the U.S. homosexual, transvestite, and transgendered implies that something was done to you, so those terms are not considered good practice by transgender people. Sexual preference, lifestyle choice means that it's selected, and some people feel very strongly that this is something innate, this is something that was wired in my brain, so why do you tell me it's a preference or a choice? So we think sexual orientation is more neutral. Certainly we avoid disrespectful language, gossiping, saying things that are not necessary for people's care. So you look great, you look like a real man or woman is certainly insult. You're so pretty, I can't believe you're a lesbian. These are things that people actually have said in clinical practice. So again, if you're unsure as a clinician, you see somebody, you're unsure, he, she, you can certainly say, I'd like to be respectful. What name or pronoun would you like to use? If the name doesn't match the insurance or medical record, and I've been told by a number of transgender women here in Peru, this is a big problem, getting the identity card changed. In the U.S. we'd say, could your chart or insurance be under a different name? What is the name on your insurance? So not making their problem of trying to get the information. And certainly, nobody is perfect. So certainly saying, I'm sorry, I did not mean to be disrespectful is not a bad thing to say if people seem uncomfortable. So again, we have materials, and we try to educate providers, we try to encourage patients to see that this health is a human right and getting good care is important. So we have Don't Ask, Don't Tell was a policy that President Clinton had when they wanted to have more inclusion of LGBT people in the military. They said to the military, if the rules say you're going to get kicked out if you're gay or lesbian, well, don't ask people that. That was thought not to be a good policy, and now we have full inclusion in the military. So we took that don't ask, don't tell and flipped and said do ask, do tell. So in other words, we think it's important for people's health that their doctors know their sexual orientation, gender identity. So I want to switch gears in the time remaining and just talk about specific reasons for specific health disparities, having made the case that it's very important to know about sexual orientation, gender identity. So as Professor Casares said, I do a lot of work on HIV and STDs. So why do we have a disproportionate HIV epidemic among men who have sex with men and transgender women? And it's not just that people have more partners. Some people do have more partners. But there's also other issues. There's biology. Anal intercourse is the most efficient way to transmit HIV, being the receptive partner. So whether it's man, woman, transgender, non-transgender person, anal intercourse is just the efficiency because of the cells in the rectal mucosa. And it's also efficient for some other STDs, gonorrhea, chlamydia. The other thing about men who have sex with men is role versatility. So this means that unique to other people's sexual behavior repertoire, if somebody is both a top and a bottom, is insertive and receptive, it means that they could be very efficiently infected by HIV as a receptive partner, and they could be very efficient in transmitting HIV as the insertive partner. So that's the unique thing. So there's biology. There's also networks. So by definition, men who have sex with men, gay men, are likely to have partners who are other men who have sex with men. So that's a subset of the population. Once the virus gets into that subset of the population, whether it's in Lima, Bangkok, or Boston, the virus can spread more rapidly because the majority of those individuals are only having partners from within that community. In the United States, this is an even bigger problem when there's racial segregation to some extent. So if a black MSM is more likely to have black MSM partners, well, that's a minority within a minority. So that's intersectionality. So the infection rate goes up. So the number of contacts may be the same, but if your likelihood of encountering a partner who has HIV or has that STD, you're more likely to become infected. There are other networks. There's sexualized networks, bathhouses, and then social media, where again people more efficiency in meeting partners. But there also are social and structural factors. So homophobia, bullying leads to early developmental stress, depression. Depression is associated with self-efficacy. I don't feel that I can negotiate so well about condoms. That's associated with risk. Criminalization, discrimination also means that people will avoid care. So somebody who's HIV infected may not know that they're infected for a longer period of time and may then be more infectious because their viral load is not suppressed on medication. In the United States, if you look at among the populations, the lifetime risk for any MSM at age 20 right now becoming HIV infected is 1 in 6. For black MSM, it's almost 1 in 2. It's that high, much higher than any other population in the United States. So that's why we focus a lot of our work on the new paradigm. There's one study, HP 10052, that showed that using antiretroviral medication made people less infectious to their partners. So we try to get people tested and know that they're infected and on treatment so that they're less infectious. There also are studies, the START study in Temprano, that said that it's better for the individual. So one part of the new paradigm for HIV is identifying people early and getting them on treatment as soon as possible. The other part is pre-exposure prophylaxis. Dr. Guinera was part of the IPREX study, which we were part of, and there have been now multiple studies showing that pre-exposure medication can decrease HIV risk. But if we're going to treat everybody, why do we need PrEP? And this is an example of the United States. We have 1.1 million people living with HIV. Almost 70% of those are men who have sex with men. And for us, the big issue is we have about half of those individuals who are diagnosed are not retained in care. So their viral loads are not suppressed. And the majority of the new infections in the United States are people who got an HIV diagnosis but have not established stable relationship and care. And so this is why we think that pre-exposure prophylaxis is still important. You know, eventually, if everybody's treated and everybody's viral load, virus is suppressed, we may not need something like PrEP. But in the short run, certainly in places like the U.S. and I think places like Peru, because some people are unaware of their infection, other people are not engaged in care. So for those who are at risk for HIV, this becomes important. But one of the side effects of the new era we have is that there is a lot of condomless sex. There was condomless sex before PrEP and before early treatment, but you can see here our syphilis trends continue to go up, and a substantial number of those, almost half, are people living with HIV, but a lot of them are not people living with HIV, and again, disproportionately among people from racial and ethnic communities.
Sexo sin condón.
What?
Sexo sin condón. Condom-less sex.
Yes.
Yeah, it was just because probably you hadn't captured that.
Oh, sorry.
Yes. No problem.
Sorry, I'm starting to go fast again. But just want to say that this is Boston, but we also do a lot of work in India, and we did a study using respondent-driven sampling. So we'd have people recruit partners, and we started off with a group of men who were married to women, and we asked them to contact their male partners. And we have a number of men who were not married to women. And we found that the rate of new infections was identical, that almost 15% had HIV, large number had syphilis, gonorrhea, chlamydia. And just so we, again, to bring this home locally, Impacta did some HIV surveillance here in Peru. You can see men who have sex with men and transgender women, very high rates of HIV in the population, as well as syphilis. So, you know, HIV and STDs are a big problem globally. I want to switch gears for transgender-specific sexual health issues. And once again, the reason for the transgender health issues are complicated. They're interpersonal issues, low self-esteem because of transphobia society is rejecting, lead to depression, self-harm, multiple risks. There's societal transphobia, there's institutional transphobia, which increases the risks here. There's also risk for lesbians. Several large studies of STIs among women in Sydney and Seattle showed that a number of women who have sex with women, if they were bisexual, also were likely to have male partners who are at high risk for HIV. And there's been data showing that women having sex with women can transmit bacterial vaginosis, herpes simplex, not HIV, but again, certainly no population of sexual gender minority people is free of other STDs, so that's why screening is important. So this is just one of the models we have to think about. This is a sort of simplistic model of how you protect people against specific diseases. You want to promote self-efficacy to have people feel that they have some control, but condoms decrease pleasure, peers may make it hard, and all these things affect safer sex or adherence to medication. But what happens is, if you have populations that have high prevalence of depression, anxiety, mental health issues, it's much harder to have self-efficacy. It's harder to promote condom use. So we were involved in a review for the Lancet of mental health issues, other behavioral health issues in MSM, and the data are very sobering. The data suggests a 40% lifetime risk of becoming depressed among men who have sex with men, twice the general population. Not having a partner, experiencing threats or violence are associated with this, but also other things such as panic disorders and social phobia are common. But the data also say that culturally tailored treatment can actually improve identification and decrease risk. Substance use is also another challenge among men who have sex with men, but once again, culturally tailored programs that include groups or support MSM identity have been successful in decreasing cigarette use and crystal methamphetamine use. Stimulant use is very challenging. It's a big problem in our community in the U.S. I understand there's issues with stimulant use here in Lima as well, but maybe not the same level as in the US. Lecturing has not been shown to be helpful for stimulant use. Important to give a comprehensive health package. So, when we talk about health disparities and LGBT people, sometimes people say this is very pathologizing, but a colleague, Ron Stahl at the University of Pittsburgh, has done some really important work and said one of the early studies he did, which was calling people in cities across the U.S. and getting a sample of more than 4,000 men who have sex with men and interviewing them. And he found that, indeed, there was a high prevalence of risky sex and HIV, and these were associated with psychosocial problems, depression, substance use, intimate partner violence. And if you had multiple, if you said yes that you were depressed, if you had substance use, you experienced violence, 23% were likely to report condomless sex, 22% were likely to be HIV infected. But then he said, that's very high compared to the general population, but that means that 77% of gay men who were depressed and had used substances and experienced violence still were not HIV infected, were not engaging in condomless sex. So they may be doing something right. So this is a whole nother area of research now, and the idea of supporting MSM resilience. So with my colleague Steve Safran and an Indian colleague, Veena Thomas, we're actually doing a study, an NIH-funded study, trying to see how do you support resilience and support behavioral intervention for men in India. Because in India, MSM are stigmatized, they're often hidden, lots of family pressures to have children, and lots of these same problems. So we did a pilot study, so-called R21, which looked like this was culturally acceptable, and that the support groups really helped people deal with their stressors and depression and decrease risk-taking behaviors. So now we're seeing whether this can decrease HIV and STDs. Going back to healthcare providers, providers again do a terrible job of screening patients for HIV and other STDs. And unfortunately, the lack of screening results in lots of other problems. So sexual gender minority people don't just have HIV risk, there are cancer risks. So for example, lesbians may be at increased risk for cancer because of nulliparity, so not having children or pregnancies. So this is SMW, sexual minority women and trans men. Tobacco, increased risk for breast disease, and also an increased body mass index, so increased weight, lesbians, which has been documented, may associate with increased risk for breast cancer. Similarly, HPV vaccination has been shown to be less common in lesbians, but more tobacco and ethanol, again, increased cervical cancer risk. Uterine cancer is there also may be a risk, and ovarian cancer. Similarly, for men who have sex with men, tobacco associated with prostate cancer, HPV with anal sex, anal cancers, colorectal cancers with high rates of tobacco and ethanol, a body mass index in lesbians, and decreased screening rates. And what we see is that there are big disparities in screening. So the issue, not just, we're not just talking about depression, substance use, this translates into populations that are increased risk for certain cancers, but are less likely to screen. And that's really what this slide. So it's a two-edged sword. The internalization of stigma, the experience of societal stigma and trauma results in behaviors that may increase your risk for certain cancers, but also is associated with decreased screening behaviors. So this is a challenge with these disparities in healthcare screening. So there are other areas that we don't have sufficient data. There are a lot of questions about optimal transgender care. There are two guidance documents, one from the University of California, San Francisco, another from the Endocrine Society, that review what we know about the different hormonal replacement approaches for transgender individuals. And so there's not one right answer, but again, it's getting providers who are knowledgeable about the hormones and who can engage in a shared decision-making process with the patients. Again, this is just the other issue of HIV uninfected men having a high prevalence of anal maladies associated with anal cancer. So there are several large studies underway about how to increase screening rates among high-risk men who have sex with men, and what are the appropriate rates of screening for cancers. And there are recommendations that have emerged as well, but this is a very important and very much ignored part of primary care for individuals who engage in anal sex, and very important population. This is just aside from the study. Joel Pilevsky, who I believe you know, Carlos, is leading this national study. Fenway's the site in Boston for this. So this is trying to look at anal cancer in men who have sex with men who are HIV uninfected. Another area to know about, a resource, is trauma-informed care. A number of individuals who are sexual gender minority individuals may have been abused as children, and that may be associated with avoidance of healthcare procedures. And so understanding how to make patients comfortable is very, very important. So the U.S. government agency a manual of best practices for this, and sort of when you're doing a speculum exam for a woman who, whether it's a transgender man or a lesbian who may have been raped, may have experienced sexual violence, knowing just things like how you approach the speculum, how you give, how you talk to women. Instead, you know, don't say open your legs, let your legs drop to either side. So this is, again, is important. And Journal of General Internal Medicine is the journal for general practice physicians in the U.S. So it's good that these kind of discussions are getting into the mainstream in the U.S. now, hopefully in other countries like Peru. There are ways to modify examinations to make women more comfortable. Not, for example, saying you have to go into stirrups, you know, different kinds of things. Even letting women insert the speculum themselves, for example, if that's preferable as well. The Affordable Care Act in the United States prevents plans from limiting coverage of sex-specific preventive services based on sexual activity and behavior, gender identity, or recorded gender. So there actually are documents now that can inform consumers how they can ask for appropriate care, whether it's hormones or as part of care. And one very controversial issue has been various kinds of surgery. So in the past, insurers in the United States will say, you know, silicone implants or facial surgery is cosmetic, is a luxury function. And now the current legislation allows people to advocate for getting this as part of their insurance, part of their routine health care. They're evidence-based models of care, so they're opt-out vaccine protocols. We use peer advocates and patient navigators. We also have interventions, cognitive behavioral therapy interventions to address syndemic factors, and focusing on resilience and harm reduction. So I want to conclude because I'm eager to have some discussion. So LGBTQ people diverse, the risks will vary. Some of the risks are biological, but behavioral and structural issues are a part of it. Screening recommendations have to be based on the specific populations and the net benefit. Expert consensus can be helpful, and it will evolve. There are approaches, particularly for HIV, about starting treatment early and PrEP, preventing cancers with anal paps that are important as well. But clearly, there are a variety of different activities, and certainly thinking about things like trauma-informed care and focusing on psychosocial issues and harm reduction and promoting resilience are part of optimal care for sexual gender minority populations. So I want to thank some of my colleagues who provided some of the slides, and thank you. We also put out a textbook, that's the earlier version, but the Fenway Guide for LGBT health to try to train providers in the U.S. So Carlos would like me to sort of touch on these issues so we can have a good discussion. Thank you.
Great. Thank you very much. No, solo, I just wanted to comment that you mentioned Ron Stoll.
Mm-hmm.
Ron is also a good friend. We know each other for 25 years, I think. Ron at Pittsburgh has a program with AMFAR, in fact. Mm-hmm. It's a program where he receives people who want to do, to be trained in LGBT health research. It's actually, normally people apply in August or something like that, and it's a program for 4 months. They start in January. They go from January to April. I think it's every year, but it's only 4 people in the whole world. So normally there's 1 person from Latin America. Also, people can know that they can Ron Stoll, R-O-N Stoll is T-A-L-L. But I mean, it's a very competitive program anyway. You guys don't have anything at Fenway?
No. AMFAR only awarded 1 of those grants, so yeah, it's a great program.
Yeah, it's very nice. But I mean, Fenway is a very large, I mean, extremely well-equipped institution. It's fantastic. So really, I mean, don't you guys get trainees or?
Yeah, on ad hoc basis. So we don't have any. There's no funding for international trainees. So we end up doing more going out and doing the training. But we've certainly had people come and visit and spend time with us. You know, it's easier for me to have trainees to do research because research, you know, we're sort of more in control of our schedule. International trainees to look at the clinical model is much harder because the patients there, the patient doesn't necessarily, the clinician's spending, having another person explain to somebody, well, this is what I'm doing here, this is what I'm doing there. But we have some local training. We have residents and medical students from Harvard do some work with us.
And if people from other countries, I mean, get money and go there, I mean, can they spend time, or you need to charge?
Certainly not charge. It's everything is on a case by case. In other words, I'm not the medical director, so I can't tell the medical director, well, we have this person coming from Peru for 2 weeks. They should stop everything and show them around. So obviously, the longer the person comes and the more skills they have, the easier it's to say, oh, well, we have this, doctor who wants to learn how to do, anal cytology, something specific. So that's why I say you can always, I'm always welcome any requests. And
okay. I mean, that's nice to know.
Yeah.
It's a very good thing. So there's one question here from Romina. She says, greetings. Are there programs focused on them or with India based on these studies?
Yes. So in India, we work with a group called the Humsafar Trust, and you can go to their website. They're very well known. So it's HUMSAFAR, humsafar.org, and so they're in Mumbai, Bombay, and they mainly do HIV prevention, and it's mainly MSM. But over the years, they've also become more politically active, and they've been big advocates against the criminal code, which first was reversed, and then the higher court reversed that, and they're doing a lot of advocacy. And over the years, they have developed more programs for women as well. So they're the most advanced organization in India. But the study that we're doing in India, which is focused on MSM, is with Humsafar, but also with a research institute in Chennai, in the southeastern part of this resilience intervention. So it's the second year of a 5-year grant, so hopefully it will show some benefit.
Juan had a question, but I think you're here, so please, yeah, okay.
I can. I'm interested in your experience and how anal cancer is in our United States, the prevention guidelines, and if cryotherapy it's the best option to treat gender warts, or there are other options more effective than cryotherapy.
Yeah, so for anal cancer, the guidelines are pretty good for HIV-infected individuals because the rate of recurrence is so high. So they recommend that anybody who's HIV-infected gets an anal pap smear, and if it's atypical, then they get follow generally on a yearly basis. The trouble is that for both HIV infected, but even to a great extent for HIV uninfected people, if you have an abnormal pap smear, but you then do colposcopy, which is essentially magnification looking at the mucous membrane, you don't see a lesion, you don't know what to do. Or if you see something that's not cancer, but it's looks funny, so you do a biopsy, and it's called dysplasia. So it's not cancerous, but it's precancerous. And somebody with HIV in that setting, the risk of it recurring is high. So doing the pap smear again and the colposcopy in a year is considered reasonable. The study I mentioned, the anchor study that Joel Palesti is leading, is for HIV uninfected men, because some studies, a colleague of ours, Andrew Grulich, in Australia, he's shown a high rate of reversion for people who are HIV uninfected. In other words, if you've got a normal immune system, HPV may be acting up, but it doesn't always progress. Sometimes it goes back to normal. So should you be, if you're looking every year and you're biopsying and you're removing any tissue that looks a little bit funny, it may be overly aggressive. And the issue is that even in the U.S., the HIV prevalence among heterosexual men, the estimates are maybe 15% of all MSM or HIV infected, meaning 85% are not. So, so if you do colposcopy on all MSM on a regular basis, it's a lot of people getting a lot of tests. So some people say it's a lot of expense. You're causing more harm than good. So unfortunately, that's really a clinical judgment issue about whether you do it. Doing it once because anal cancer can be asymptomatic, I think, is indicated for all MSM who have had anal sex. But if you're HIV uninfected and the test is negative, there's no guidance right now about when you would do it again. If the test is a little bit atypical, should you repeat it in a year, 5 years? That's not decided. For HIV infected people, there's more of a consensus, because even if you're on treatment and you have a high CD4 count, there's still some immune deficit that says that HPV is more of a problem there. In terms of treatment, cryotherapy is appropriate. There's also imicramod, so there's, which is podophyllin-like medication. Nothing is, no one has been shown to be better. I think a lot of clinician is most comfortable using. The best answer, which is not helpful for adults, is HPV vaccination. But I understand that the HPV vaccine is not widely available here, particularly for young MSM, because that would be the ideal.
Well, actually, it's available
For all people now?
But it's not part of the program,
So
Minister Health program.
So it costs?
You can purchase the vaccine. It's expensive right now. It's more than $100 each shot.
So that's expensive, and the challenge is, the reason, countries like Australia just said, it makes sense that they just started doing it, and they've already shown dramatic decreases in HPV-related disease by early vaccination. I was being a little bit facetious because, the best time to do the vaccination is before somebody's sexually active. So how many 10-year-olds know that they're gay, you know, and that you know, in the past they said, well, you know, if we vaccinate all women, then we're going to have, then we'll have herd immunity, then the women will transmit to men. But if there's an exclusively MSM population, then maybe in many generations there may be some trickle-down effect, but it's not going to help the next generation. So we try to push vaccinating men and young men and women. You know, but it's not widely successful in the U.S. There are better programs in the more liberal states. You know, we talk about blue states being more progressive and red states being more conservative. So
25 years.
Yeah, but up to 25. But like in Massachusetts, it's now routine in preteens. It is accessible. In a state like Texas, they refuse it for young women because they said it's going to condomless sex.
Yeah, well, I guess there was a time when the Ministry of Health bought those, vaccines for MSM even, but it was just a one-time or two-time thing a few years ago. But I think the other thing is the types. It's not useful for all the types of virus. So
no, but most, you know, in the newer vaccine is non-covalent, so it's 9 types. But again, it's, you know, it'll have a longer patent, so it'll be more expensive for a longer period of time. Yeah, so that you know, won't get 100%, but it'll get most. So.
Anyway, there's another question actually from Seattle, I think. There's an interesting, it's from Madison, no, from Irene. There's an interesting evidence in Canada and the US about LGBTQ youth being more likely to teenage pregnancy than their heterosexual peers. What can be done by healthcare workers in order to prevent this? Is there any ongoing research on this topic? Have you included any guidelines for treating teenagers? Thank you, and greetings from UW, Madison. Okay.
Yeah, no, this is it's a great question. You know, the studies are, I wouldn't say they're definitive, but I think they're very provocative, and I think that there are a couple things going on. It's not one thing. I think for some youth there may be gender, sort of the evolution and almost like an experimental phase of saying, well, I'm a young woman, I know I like women, but I'm not totally sure, so I'm going to, you know, I'm not totally comfortable with embracing a lesbian identity, so maybe I'm showing that, you know, showing my parents, I'm showing my friends that I actually am heterosexual by doing this. So there's that phenomenon. There's some you know, there's similar for some gay youth or youth that are questioning that may that are male that may not be sure of a gay identity. That there's experimentation that's going on. So you know, there's not, to my knowledge, there's not like a separate youth pregnancy for LGBT individuals, but there are programs in many of the big cities, sort of again around sex education. So again, you have this real divide. The U.S., you know, as our election shows, we're in the middle of a cultural civil war, and it's ugly, unfortunately. You know, so that again, places like, you know, Massachusetts, most high schools have gay-straight student alliances, and most high schools have sex education starting at a relatively early age. And then many of the states in the South, and then some of the states in the western part of the country, school boards have a lot of local autonomy in the U.S. historically. So there definitely are school boards that will not have any sex education through high school. You know, people who graduated will never have sex education. So those are the most vulnerable places where there's no discussion of these issues.
Okay, people keep thinking, and please keep thinking of your questions. I have one question that is more kind of overarching, philosophical. It has, components. For example, we're talking here when discussing LGBT health in medical practice, to some extent, if we're talking about health services, about a certain degree of segregation. So, and it may have good things, but also some negative consequences, no? Because it's kind of siloing, no? Creating a ghetto within a hospital or whatever. We're going to, no? So, I mean, the extreme would be sort of an LGBT medical office, no? That kind of thing. But probably we're not talking about that. We're talking about incorporating practices among physicians so that people can identify as LGBT and their specific needs can emerge, you know, can be assessed, no? So that kind of thing. So yeah.
I want to respond to that because
Yeah.
it's an excellent question, and I'm like, why have a place like a Fenway? And so, you know, because I think your point is really important. You know, if we want all, you know, healthcare workers to have knowledge about LGBT health, we shouldn't segregate. On the other hand, to be able to develop best practices, sometimes you need a critical mass. In other words, because if LGBT people are, it's not necessarily a discrete population. You know, it's not like race or ethnicity. In other words, particularly sexual orientation may evolve over time. Gender identity may evolve over time. And then, as I said earlier, you know, identity, attraction, behavior are not identical. But if we even if we take all that and we just say, what's the biggest circle we can draw? It's never going to be over 9%. You know, I mean, more studies are 3 to 5%. Some are a little higher. You know, so that means that in any one center, on average, the minority of the patients are going to be LGBT. And so to develop best practices, it's very hard if busy clinician, if they have 1,000 patients and then they have 50 who are LGBT and they're all different. You know, some are gay, some are bisexual, some are lesbian, some are transgender, men, transgender women. It's very hard to develop generalizable principles. So what we've come to think about places like Fenway are centers of excellence, you know, and in the United States, for example, there are less than 10 community health centers like Fenway. So there's one in New York City, Callan Lord. There's Howard Brown in Chicago. There's Whitman Walker in Washington, D.C. Chase Braxton in Baltimore. The LA Gay and Lesbian Center. There's Lion Martin Clinic in San Francisco, which is mainly focused on women only, but focusing on lesbians and bisexual women. Then there are a few other programs that are, you know, what's turning out now is, as I was saying to Professor Casares walking over, that the Obama administration, because of increased civil equality, has really made it sort of like the presumption is, why aren't different services, you know, if this is a minority in our population, then what are we doing to address the needs of the minority? That should be, the resources should be at least proportionate to the minority, and if it has health, if the minority has disparities because of discrimination, then perhaps more resources. So some medical schools now are developing LGBT clinics within the medical school, partially to concentrate care and partially to educate. But nobody thinks that every small town and every private practice should have the same standards. But you know, just like in some settings with HIV, I'm sure this happens here where in Lima you've got lots of centers that have lots of expertise. There may be somebody in a smaller town who the primary provider wants to do a good job but doesn't have a lot of experience. So maybe calling somebody, maybe asking questions, you know, and similarly, our education center, the idea is to spread the education, you know, to busy primary providers, so at least there's a minimal level of competence, you know, it doesn't have to have specialization necessarily.
Interesting. ¿Alguna pregunta ahora? Okay.
I have a question. Right now, it's a recommendation given by the WHO, but here in Peru you have it, and I think that PrEP is a topic which has a lot of stigma. for example, some health care provider can say that, you know, if we give this, it'll make people more promiscuous. So how do we address those obstacles?
That's an important issue, and I know that Professor Cáceres will comment also. So provider, anticipated risk and provider attitudes is a challenge in the U.S. too. So it's changed. You know, certainly the U.S. was the first country to approve PrEP, and you know, in the past couple of years, the numbers have increased dramatically. But still, the U.S. CDC estimates that there are more than 1 million Americans who would benefit from PrEP based on their behavioral surveillance studies. And Gilead presented data recently, and maybe there are 80,000 Americans who started PrEP now. So 80,000 is huge compared to several years ago, but that's still under 10%. So providers, so we have challenges for providers in the U.S. In terms of PrEP availability, I know that Impact is going to be involved in a demonstration project, but I also know that you're working with Unitate, so there'll be another demonstration project starting here as well. So, so there should be more access to PrEP here in Peru, but certainly the issues of people, you know, the at-risk community knowing about it, and people feeling comfortable, you know, in the U.S., there, you know, Facebook, there's a lot of activity on Facebook, and there are a couple of gay community leaders. Larry Kramer, a very famous AIDS activist, who's helped start ACT UP, and then somebody owns a big company that makes antiretroviral treatment available, AIDS Healthcare Foundation, very anti-PrEP. So somebody calls somebody who started PrEP a Truvada whore, you know. And so some of the activists, just like in the days of ACT UP, sort of said, I'll wear that with pride. And so they made T-shirts that said Truvada whore. So there's, you know, like a lot of these issues, you know, there's sort of the cutting-edge activists who are fearless and are influencing some people, but there's still the majority of people, you know, young people coming out, people from poorer communities, less educated, who obviously have a lot of the baggage from the society, you know, the culture they grew up in, and certainly saying, I want to have sex without a condom, and I want to be safe, is a brave thing to say. And then if the doctor says, you know, I don't want to provide this to you, so that becomes a problem. So it's a work in progress, and I'm sure here in Peru things will evolve too, and probably, you know, probably more rapidly in Lima than in other parts of the country.
No, that's true. Actually, it's very interesting because, in a way, the emergence of PrEP, in a way, it had happened with male circumcision, although it was essentially circumscribed to Africa. But PrEP is actually more usable across the world, and its acceptance as an effective means of prevention, in a way, implies the official status of combination HIV prevention. So really moving away from the condom-based paradigm, condom and behavioral change, to a paradigm that is more sort of tailored to individual needs, because many people are already doing things differently. Some people are using even sorting, so getting tested and sort of estimating the risk of the partners, and based on that deciding if they use condoms or not, or using the seropositioning thing, which is they assuming that if they are insertive, they have less risk, which is in a way true. It's a lower risk. So people play with that. There's a whole culture, not necessarily here, in other places, in the US, definitely it is a practice. So I guess people have been sort of fabricating their own prevention strategies, taking things from here and there. So I guess, in a way, people have established combination prevention regardless of what the medical system has done. So we have to get there and try to at least influence that discourse on combination HIV prevention, which is an official UNAIDS strategy that hasn't been really fully deployed, fully presented, established, and we need to do that. And there, PrEP has a role. No? WHO has already accepted PrEP as a strategy that is important for not just MSM or key populations, but for any person at substantial risk for HIV. And what is extremely interesting is why in so many places there has been so much of resistance to PrEP. No? And probably it's a combination of the old fear of clinical trials, of the issue of dealing with drugs and pharmaceuticals, which is a real problem, probably the issue of fear of sexuality and sexual freedom, no? Which is the same thing happened with women and the emergence of contraception, of oral contraception decades ago. So it's fear of people not being restrained, no, by fear. In that case of pregnancy, in this case of getting infected with HIV, and both within the community with the Truvada whole thing, and from medical system, no, with doctors, and always the idea of controlling and unfortunately, I'm also part of a medical community, but I have to recognize that. And I guess what we're seeing is that in many places, those people who choose PrEP are people who are already not using condoms, but who want to prevent HIV. So a large majority of people in the UK, in the United Kingdom, who became part of a PROUD study, which was successful, which found 86% effectiveness. It was a demonstration study. They were mainly people not using condoms who wanted to prevent HIV, and the results were so clear that it's considered a new wave of proof that is stimulating many countries to improve PrEP. Unfortunately, not the UK, which has been a big problem there, no? because of cost, because they get the highest cost Truvada, yeah, it's a lot. Although France, which did another study at the same time, the Hypergay, they decided to fund PrEP, and they are paying for PrEP. Because, PrEP is not something people will use for the whole life. It's something to use during those years of life when people are very sexually active. But people can be very sexually active 5, 10 years, but then people get tired, people... there's a substantial number of people who reduce their sexual activity, they get partners, etc. So it's different, no? Whereas treatment is treatment for life. No? So I guess it's a very complex topic, and yes, I think there are plenty of studies ongoing or coming, which are going to focus on PrEP here, and it's going to be interesting. No? Anyway, another question that I had, what do you know about the process in medical schools in the US in terms of adopting content related to LGBT health? Issues, your reflections, the importance or impact this may have had, what would you say?
It's a work in progress. Again, I can't emphasize how it's one of the more dramatic things that's happened in the Obama administration, and one that doesn't get a lot of publicity because countries, there's such turmoil that the administration does it more quietly. But the fact that there were these reports by the Institute of Medicine and the National Institutes of Health, then all of a sudden, it used to be that most of the grants around LGBT people were HIV focused. And now, because this administration says, health disparities cause health problems, and so we should find out how racism affects Black people accessing care, and how do you develop culturally tailored interventions so you have, improved cancer screening rates, mammography for African American women, for example. So it's the first time that some of the NIH grant announcements actually will say, racial ethnic minorities, sexual gender minorities. So there's more scholarship, and many of those people who do that health research are in medical schools. So they're people. The faculties in many places now have people who are doing research in this area, and obviously say, if we think this is important enough to study and improve the health of the population, we should make sure that our students know about it. But again, it's not uniform, and some schools are affiliated with religious institutions and have, are more traditional, and it's not consistent. So it's not like a standard practice at this point. But many things that relate to what are considered lifestyle are not consistent. Like nutritional education in medical school is not consistent, for example. So I love it to be consistent and high level, but the fact that at least it's starting is important. I mean, the other thing is that 20, 30, 40 years ago, being out as a medical student was somewhat risky in U.S. medical schools, and now because it's the start of the school year, a week and a half ago, and the medical school had their reception for LGBT students, for the new year at Harvard. So so certainly things have changed a lot.
Different times.
Yeah.
That's interesting. Yeah, I think the medical schools here have traditionally been more conservative, but I don't know. Maybe that's changing. No?
I think this is one where I think that it's definitely the Obama administration, and I think it's jumped ahead. So I don't think this is happening as much even in Europe or even maybe Canada or necessarily Australia. So I think that's something. I mean, this is very recent. Again, certainly less than the 8 years, because it wasn't even the first couple of years was still the economic crisis, but then they started being permissive, and by this term they're being much more. Not directed, but just sort of very clear. So I think people at the NIH has an office of sexual gender minority health within the NIH. It's not like a big office, but like the Office of AIDS Research or the Office of Women's Health, it means that they have a focus and they want to make sure that the research reflects that part.
They have released requests for applications for research.
Yeah.
But is there any sort of permanent funding stream for that, or?
No, it's not permanent, but because unfortunately, NIH is even that's very political. So the administration can do a certain amount, but Congress can cut the NIH budget. So I think they're cautious, but they feel more comfortable writing it into RFAs when it's relevant. So if they have an RFA about health disparities, it'll be included. And I think 20 years ago they started. You're very familiar with the National Institute of Mental Health. There's an issue of the National Institute of the National Institute of Minority Health and Disparities, NIMHD, a smaller institute, and it was just in the last couple of years that institute was mainly focused on race and ethnicity disparities, and now they were told you should include LGBT disparities as part of your research portfolio. So they do have RFAs that are in that regard.
Oh, interesting. So I guess it's something to research, something to look at, no? Because I mean, sometimes people are not so much aware, and I guess lots of research and focus on HIV, but probably more is needed, particularly here, regarding LGBT. Yeah, absolutely. Any other question? People might,
yeah, Dr. Mayer. I have one question. I think you mentioned some experiences in Brazil, which I believe is the country more similar to Peru. I want to know what gaps do you find in implementing all this information that we can find in these reports or guidelines made in the U.S. implemented in a country that is really different?
Yeah, that's a great question. Brazil, as you're more aware than me, is a very big and diverse country. So again, I think there's a few academics who are very interested in this area, but there's not yet like a broad, separate LGBT health research effort independent of necessarily HIV or STDs. But there's certainly researchers who are very interested in this area who want to do more. So a colleague, Professor Cáceres knows as well, as Beatrice Greenstein at Faircruz, and who does great HIV work, but also wants to do broader LGBT work. And there's several researchers at the University of Sao Paulo, Maria Veras.
Maria Veras,
yeah, very interested. Again, more broad, holistic, and up in Bahia, Inés Dourado. Yeah.
Dourado. Well, they are all involved in, particularly Inés Dourado, Beatriz, with Valilea, at Fiocruz, the group at the University of São Paulo, well, Rio Grande do Sul as well, Porto Alegre. There are some other people.
Yeah. So I think there's interested academics, but I don't know yet of like a freestanding, LGBT or even MSM clinic that's not sort of part of an HIV research effort or a prep effort yet. But I think people are starting to think about this, and Beatrice and Vajalea have visited Fenway and we've met about this. So I think again, it's as you know, the political situation there is probably not the most conducive to getting new things done.
I mean, the world is getting crazy.
Yeah. We don't know what'll happen with President Trump either, so it's our nightmare. But anyway, but I actually think this, as I say, this is one of the best contributions of a national administration being more permissive. So I think there's much more been going on in the U.S. just in the last few years, and if it's again, if it can be a model that other countries will adapt as appropriate for their cultures, I think this is something that can continue to grow scholarship in this area, and certainly, clinical education and clinical services. Because I think particularly, I think here, Cayetano, Professor Cáceres is first and foremost, this frame of reference is always around human rights. So I think it's a very important frame for healthcare is a human right, and if knowing people's sexual orientation, gender identity is part of, is an important part of how they access care, experience it, how they health outcomes, then it has to be tied to human rights, and hopefully that helps in the discussion.
Okay, I think we need to end soon, so I don't know if So I just. We've come to an end here, and I just want to thank a lot Ken, Professor Meyer, who is so talented, so hardworking, and so committed. No, I guess he's been working all day, and he's spoken here for an hour and a half. No, and well, I know some of us make this kind of work part of our life, and he's an example of that. No? So I guess I'm really honored to have been his friend for a long time. We've shared various spaces, and really would be very nice if we can. I mean, as I said, we are trying to build a space here in terms of a reflection at the medical school, and hopefully in other places in other medical schools in Peru to think of this, because this implies thinking and guidance. No, this is not something that happens suddenly. So I guess we need to establish that kind of reflection, and hopefully we can. I mean, we'll discuss. We'll talk a little bit after this presentation. So maybe something can come up. Because there's a lot of things to do. No, we recognize that. So, but anyway, I just wanted to say that it's been a honor. We've been lucky to have Ken, Professor Meyer, here with us tonight, and we hope it's not going to be the only time we're going to